to me, the cost was okay, because when an investor is thinking of a trisacrity, which is going to be like at least 6 months, beginning with a 13,000 or 14,000 rupees for neuroprecision was okay. Because your decision, you save money. You save money.
Respected chairpersons, dignitaries, seniors and friends, I primarily am a neurosurgeon, but I chose the easier path out and chose to do endovascular neurosurgery instead of microvascular procedures. So today I shall be speaking about management of vertebrobacillar aneurysms and the strategies we take to manage them. My domain of interest for today will be the V4 and the basilar artery. I won't be including the basilar top aneurysms. And my main reason for doing that is this region is pretty complex in the sense of perforators, pica, the origin of the anterior spinal artery, for which the decision making in this region has to be done in a case-to-case basis and again a tailor-made way. My previous speakers elaborated the aneurysms in a beautiful way, and surgical role is still there in many of the cases. Flow diverter is still not the final solutions to all the fusiform aneurysms and the difficult cases we encounter. The outcomes aren't as good as is shown in literature in all cases. And the main reason why we need to look after this part is there is a varied dominance of the vertebral arteries. The perforators arising from the basilar, the pica and the V4 segment are varied from case to case. The anterior spinal artery, whether it is a paired or a single one, is again an important factor. Fenestration also plays a role, but in my cases I haven't shown any fenestration. I haven't encountered any such till now. Now coming to the dominance of vertebral arteries, a dominant vertebral artery is defined as one which has a larger diameter of more than 0.3 millimeter than the other artery. This is the strict criterion of diameter to dictate it as a dominant vertebral artery. And the angulation of connection of the vertebral artery to the basilar artery in a more straight fashion is also another criterion which is based on CT angiography. Now, this is important in these cases as sometimes we have to sacrifice the vertebral artery to deal with a V4 aneurysm. So this dominance needs to be taken care of and needs to be ascertained prior to dealing with the case. Now, these are the various morphology of the vertebrobacillar systems. As you can see, in few of them there is a co-dominant system. In one, there is a system in which there is a hypoplastic or sometimes aplastic vertebral arteries. So relevance, as I said, is in relation to sacrificing the artery and the need for a balloon test occlusion. When there is a co-dominant system, there is no need for a balloon test occlusion to sacrifice the artery. But when a dominant artery needs to be sacrificed, a balloon test occlusion has to be done. And it has to be a selective one exactly within the vertebral artery to see whether the cross flow is adequate or not. So suppose an aneurysm like this, we can sacrifice it by putting coils exactly in this area. But again, we have to take care whether how the spinal arteries originate and how the pica originates. If the pica is involving the aneurysm, this sacrifice cannot be done and a more conservative or a diversion approach has to be adopted. As we all know, the perforators in this region are the most crucial. The basilar perforators for the pontine, the V4 and the pica perforators for the medulla are most important. One of the major concerns related to use of flow diverters is occlusion of perforating arteries. Flow diverters have been designed such that the perforating arteries are saved. But if the perforator inlet is closed by more than 90%, then it may cause a perforator stroke. And as we all know, anterior spinal artery originates in a paired manner from the vertebral arteries. But in a few cases, there is a singular origin. So while sacrificing a vertebral artery, one must be careful whether this anterior spinal has a paired origin or a single origin, but it is very difficult to ascertain unless the cath lab is that good and we are able to see both the origins. So I'll come to my cases. I'll share 5 cases. This is the first case which presented to me probably a month after the patient was admitted in some other hospital. Patient was diagnosed with a mid-basilar aneurysm and had hydrocephalus, for which he had been put a VP shunt. So this is the first presentation. He came to me and I had planned for a flow diverter, but he could not afford. Went off, came again 1 month back to another hospital where I did the procedure. Sorry, these are images from 6 years back, so they're a little bad, but this is how we have done. We have gone through one of the vertebral, put a microcatheter into one of the PCA, and here we can see the flow diverter being carried into the PCA. Now the reason for putting the microcatheter so far is when we push the flow diverter into the microcatheter, usually the microcatheter pulls back. That is the reason it has been put such. And as we go forward, we put the flow diverter from the top of the basilar across the neck of the aneurysm into the vertebral segment. Now, this has been done and a follow-up was done with the patient 6 months following the procedure. In this case, one thing I need to say is we found that there is a dissection in the aneurysm. So while taking the microcatheter, we repeatedly went into the endothelial pseudopouch instead of the true lumen. But finally, the true lumen we achieved before putting the flow diverter. So this is the follow-up at 6 months. The patient was off tracheostomy at this point, was independently able to feed and walk, but he was not able to do his work. Still, we can see some stenosis in this part. Probably there is some clot burden in the aneurysm which is still pushing the basilar artery, but the patient was doing well and is still under follow-up. Now this second case is a V4 segment aneurysm just close to the vertebrobasilar junction. This we dealt with a stent-assisted coiling, but on follow-up the stent had occluded, but patient was doing well. This third case is again a dissected giant aneurysm of the vertebral V4 segment. We actually, somehow the video got displaced. We put a flow diverter. Patient got discharged on day 7. But after going home, this patient expired. Now, we exactly cannot ascertain the reason, but I had not put any coils within this aneurysm prior to the flow diverter. So probably that is the reason it would have acutely thrombosed or ruptured, which caused the fatality. The fourth case is a case which I have recently done. He presented with low GCS and a poor neurological score, diagnosed with a dissected aneurysm from V4 segment into the basilar artery. Here again we planned for a flow diverter. This is the microcatheter being carried off into the PCA, and then the flow diverter is being taken into it. As you can see, this is a vaso-CT which shows the flow diverter has good apposition. And as we have gone forward with our practice, vaso-CT has become mandatory when we put flow diverters. Without proper apposition of flow diverters, the success is not so good in these cases. And this is the last case in my series. This patient presented with headache. Again, a very similar aneurysm extending from the V4 to the basilar. Again, the plan is same. Taking a flow diverter across the aneurysm. We can see the microcatheter again being carried through the true lumen into the basilar. And then the flow diverter being delivered. Now this procedure may seem very simple, but the nuances of the procedures are many. these flow diverters often cause occlusion of the perforators, so we try to keep the flow diverters below the mid-basilar segment so that the basilar perforators are saved. But anyway, the medullary perforators get involved in these flow diverters, so they have to be put on antiplatelets and intraprocedurally on anticoagulants to prevent any obstruction of the perforators and the main vessels. So this is again a similar picture, but this patient has a good outcome. He has no issues. So